research done on sleep, really just dating back probably less than 100 years. Go through some predominant theories of why we sleep. Talk about how sleep is organized, how sleep develops as we age. I'll go through a little bit of the anatomy of what happens during sleep, some symptoms of when we have abnormal sleep, and then talk about a few selected sleep disorders. So a little bit of the history. So back in 1925, this is when the EEG was first invented. And so this is when it became more interesting to look at sleep and what happened during the EEG, on the EEG tracing, during sleep. And in 1936, using some of these new technologies that they were able to develop, they were able to see that certain times during sleep, the actual brain was really awake. So despite the fact that the person had their eyes closed and was, for all intents and purposes, asleep, the brain looked very much like an awake brain. In 1937, Loomis did some studies to try to figure out exactly what the brain looked like during sleep when people were thought to be dreaming, and did this by trying to awaken people, ask them if they were dreaming, and then document what their EEG looked like just prior to being awakened. In 1953, Aserinsky and Kleitman actually made up the term rapid eye movement sleep, or REM sleep, and this is when they determined that the EEG actually looked most awake during sleep, and that is when it appeared to be that people were dreaming. Finally, in 1955, Dement was the first person to classify how we cycle through different stages during our sleep, and how these stages appear to be similar during cycles. Finally, in terms of looking at the anatomy of sleep, Juan Economo looked at the brains of the people after the 1950s epidemic, when people developed encephalitis cardiac attacks, and was able to see changes pathologically in the hypothalamus of the brain that he surmised were leading to some of the sleepiness that people were seeing with the post-encephalitic brain after the flu epidemic. Then in the 1940s, Robert Moore was able to determine that the suprachiasmatic nucleus was a really important nucleus when it came to the sleep-wake cycle. And we'll talk a little bit more about these anatomical structures later. In 1948, Muzzi and Lagoon were further able to find areas of the brain that appeared to be activating. So they were able to find what they thought of as the reticular activating system. And they did this in studies of actually rats and cats. Finally, in 1996 and 1998, another important marker in the history of sleep is these two people actually in two separate labs found the same neurosubstance, one called orexin and the other hypocretin, and we'll see later how this is a very important advance in terms of some of the sleep disorders that we've been able to characterize. So why do we sleep? This has actually been a question that's kind of bothered us throughout the ages. Aristotle was the first person credited with writing significant amounts of text about why we sleep. And he actually at that point thought of the heart as the most important organ of the body, and thought of the different stages, or wakefulness versus sleepiness, as whether the heart was turned on or turned off. He actually didn't think that dreams were important. He thought they were just a side effect of sleep. And that sleep came about because humors that were released from your food turned off your heart, and that's why you would sleep. Later on in the 1980s, Reichschaffen and Bergman did sleep deprivation studies in rats to try to determine why we sleep. And he actually found that sleep-deprived rats seem to have lower body temperatures. They appeared to eat more, but be skinnier, and they also had an impaired immune system. And so they postulated that maybe we slept in order to better thermoregulate ourselves, to conserve energy, and to keep our immune system strong. And so there's four major, theories of why sleep functions, or why we sleep, and what is the function of sleep. And truth is, nobody knows the answer to this, and this is just kind of four schools of thought. And a lot of these thoughts are based on observations that we see on the EEG and on people who are sleeping. So the first of these theories are the recuperative theories. And these are the people that believe that we sleep basically to recuperate from what we do throughout our day. some of the evidence that they point to when talking about recruitment theories is that, for example, after we exercise a lot in the day, that we tend to have more slow wave sleep the nights after we exercise. And so potentially, our body needs to recuperate in the slow wave sleep from the extra exercise that we got that day. Other potentially more practical people talk about circadian rhythm theories, that all animals sleep, and potentially we just sleep because we want to be awake during light hours and be sleeping during the night hours. And so this is just something that's developed over the ages to conserve energy while it's dark when we can't see and can't afford for food and these sorts of things. Developmental theorists really talk about how sleep changes throughout the ages, how REM sleep seems to predominate when we're in childhood, and then slow wave sleep increases again as we age, and then decreases again as we get very old. And so because they see these changes in sleep as we age, these people theorize that it's important developmentally that sleep occurs, and that there's developmental stages and advances that are being made during sleep, and this is why it changes as we age. Now finally, some people think that we sleep in order to consolidate memories. And some of the evidence that they point to when they talk about this is that, for example, after a full day of studying, we tend to have more REM sleep. And so it's thought that REM sleep and other stages of sleep might help to consolidate our memories and long-term memory. And so because of that, they believe that sleep function is actually just to consolidate our memories and consolidate what we learned throughout the course of the day. Now let's switch gears a little bit and talk about how sleep is organized. So I'm sure a lot of you have heard about some of the different stages of sleep, whether it's REM or non-REM sleep, slow wave sleep, and these sorts of things. And truth is, despite the fact that these very strict guidelines that define how sleep is organized, sleep in reality is a continuum. And the best example I can give of this is, when you're drifting off to sleep, right, kind of when you're watching television and you're kind of sleepy, and if something wakes you up right when you're drifting off, you can still kind of remember the show you're watching and remember the details of the show, even though you know your eyes were closed when you were asleep. And that just goes to show you how much of a continuum it is, because if you strap the EEG to your head at that point, likely you would be in stage 1, potentially in stage 2 sleep at that point. But you're obviously aware enough of your surroundings and awake enough to remember the television show and some of the details that you heard from the television show. So it really just goes to show you how it's a continuum. And even though I talk about these very defined cycles of sleep, that we're kind of floating up and down through these cycles, and so it's not as defined as it actually seems based on the EEG criteria. So like I alluded to, sleep is divided actually into 2 independent states. They talk about REM sleep and then non-REM sleep. And then non-REM sleep is further subdivided into other stages, and this is this classic state 1, 2, 3, and 4, which is kind of the old classification. Very recently, in the last couple of years, actually, they've conglomerated stage 3 and 4 into just a single stage called M3, and that's all slow wave sleep. They used to divide slow wave sleep into 2 types, but now it's just called slow wave sleep. So really, it's just 3 stages of non-REM sleep. And throughout our night, non-REM sleep and REM sleep alternate, and so we go through periods of time basically where we cycle up and down, and sometimes we're in REM, and sometimes we're in non-REM, and I'll have a picture a little bit later to show that a little bit better. Most people, and this changes a little bit as we age, and also differs from person to person, but for most people around our age, the cycle lasts approximately 90 minutes. And so because of that, you're able to generally get through about 4 to 6 cycles in a good night's sleep. And so we see here a picture of this. And so you can see how throughout the course of the night, we cycle through several cycles. And in this one range, it's going through 6 cycles of sleep. And so they start off with awake sleep, and you can see early on in your night, your periods of REM sleep are really, really short. So right away, especially in this first cycle, we go all the way down into our deepest sleep, into our slow wave sleep. And so this is what some of the recuperative theorists are talking about, that right away, as soon as we get to sleep, our body puts us into slow wave sleep, and And we have nice long cycles of slow wave sleep early in the night and early during the cycles. And then as we get more and more sleep throughout the night, we get less and less slow wave sleep. And you can see even late in the night, if you were to continue sleeping, let's say for 10 or 11 hours, that you're not getting any slow wave sleep by the end of the night. What you're getting mostly is nice long stretches of REM sleep. Okay? And some people, a nice way to remember this too is that, I don't know if you guys have noticed, that if you get short nights worth of sleep, that sometimes you think, my goodness, I don't dream. But it's those days on the weekend that you're able to sleep in and get 10 hours of sleep that you notice, oh my goodness, I had so many dreams, it felt like you were dreaming when you woke up. And it's because our most kind of active and memorable dreams tend to happen during REM sleep. And we're getting a lot more REM sleep when we're allowed to get the nice 10 hours of sleep that we do. And because of that, it feels like we dreamed a lot more. So this is just kind of in summary of what I just said. The first two cycles tend to be dominated by slow wave sleep. And then later on in your sleep night, you will get very brief episodes of slow wave. And that your REM sleep increases from the first to the last cycle, so that later on you can get really, really prolonged periods of REM sleep. So this is really important when we take a history of a person's sleep in a doctor's visit, for example, because if a person tells me that they do things during their sleep, I'm going to ask them if they tend to do it in the first third of the night, right when they fell asleep, or if they tend to do it in the last third of the night, right before they wake up. Because that tells me what stage of sleep they might be doing these things in. Because if they tell me that they tend to always do whatever they're doing that they're telling me about during the first third of sleep, then I know it could be something that's potentially more likely coming out of slow wave sleep. Whereas if they tend to do it right before they wake up after they've been sleeping for a period of time, I'm going to be thinking about the sleep disorders that tend to arise out of REM sleep. So just again, to recap, we have three basic states, and this is important when we start to talk a little bit more about the anatomy. And the three states that we always refer to are awake, the non-REM, and the REM. So before I talk a little bit about how we classify these based on EEG, I'm not sure if you've had any of your seizure EEG lectures, so I just wanted to go through just quick basics of the EEG. Basically, how we describe the waves that we see in the EEG is based on the frequency of the waves. So the number of waves that we see in any given second of recording. So delta waves are anything that happens about 4 hertz. If we see 4 waves in 1 second, that's delta. And you go through beta, alpha, and beta getting ever quicker with more waves happening during that 1 second period. When you're talking about EEG related to seizures and to epilepsy, they look at an EEG in a 10-second cycle. So sleep medicine is a little bit different because when we define things in sleep, we actually look at a 30-second age, and that's called an epoch. So the EEG that we look at is actually a little bit different when we're talking about sleep EEG versus one that you would do for epilepsy potential. So this is just a summary of how we define the stages of sleep based on the EEG. And all of that kind of the historical perspective that I gave you of those people that tried to define sleep basically did it based on the EEG. And so because of that, we've defined these very discrete times during sleep, although I want you to remember that it is still a continuum. So despite the fact that in one epoch, or a 30-second period, you might see characteristics that put us into one stage, again, this is a continuum, and we're cycling up and down throughout it. So when we're awake, basically the easiest way to remember it is that you see kind of a very active, disorganized EEG, and you can expect that because you're thinking of all different things, you're doing all sorts of things with your body. And so you can imagine that you're seeing all this disorganized firing that's very active. And basically as we go down through sleep, the EEG gets a little bit more organized and a little bit less active looking. So in stage 1, we see about 50% of the activity that looks approximately like we're awake, and then 50%, less than 50% of the activity contains this alpha rhythm, which is this rhythm that we see at the back of the head, when we're kind of not dozing off, but we've got our eyes closed and we're relaxed. And at that point, we often see eye movements that are kind of just slow and aerobic. stage 2 sleep, that's the one that's kind of the most interesting on the EEG. We see kind of the appearance of moving things like sleep, spindle, or K complexes. And it's not necessarily important to know what those are, but just to know that it's in stage 2 sleep that we kind of see these classic sleep features that we look for and that we define. And that's the hallmark of stage 2 sleep. And then stage 3 and 4 is the one that's now combined as slow wave sleep. And that's basically when we're seeing more and more of those delta waves. So more and more of those really slow waves. And it looks very organized because the whole brain is doing it all at the same time. Finally, in REM sleep, the EEG actually looks very awake. But together with that, when we're doing an EEG for sleep purposes, we actually are able to monitor both eye movements and muscle activity. And so during a REM sleep, we see what looks like an awake-looking brain. Together with that, we see a lot of rapid eye movements and then absolutely no muscular activity in the rest of the body. And that's not something you ever see while you're awake. So that's what actually characterizes REM sleep. So this is, that was a lot of details. This is mostly what I want you guys to remember, basically, is that awake is very disorganized, there's lots of activity, that in non-REM you basically get more and more organized until in slow wave you see kind of this nice, organized slow wave activity. And in REM sleep you look awake from an EEG perspective, but you've got no muscle tone in the rapid eye movement. So dreaming. Despite the fact that we think classically of REM sleep as being when we dream, we know now that dreaming actually occurs during REM and non-REM sleep. So not just during REM. The dreams that we get during REM sleep, though, tend to be a lot more vivid, a lot more bizarre, have a lot more emotions associated with them. And so those are the ones that we remember when we wake up. And so that's why sleep was originally being defined, and dreaming was originally associated with a certain stage. That's why it was associated with REM sleep, because when you wake someone during REM sleep, they'll remember very vivid, bizarre dreams. And as you all know, external stimuli can be incorporated into dreams. And so, for example, if you hear a door slam or a loud noise while you sleep, that can definitely be incorporated into your dream as your brain potentially tries to make sense of this activity, even though it does have a very awake-looking appearance during that time. So now we talk a little bit about how sleep changes as we basically are born and then grow up. So the time spent in REM sleep is actually greatest right before we're born. So if you were able to look at the EEGs of babies prior to being born, this is when you actually see the greatest amount of REM sleep. And interestingly, we don't see any slow wave sleep until a baby is approximately 4 or 5 months old. When they're first born, they're actually just alternating between REM sleep and stage 2 sleep, so this light sleep. We all know that babies tend to sleep a lot more, and basically as we get older, we require less and less sleep. Interestingly, there's another peak in sleep requirement, and in our teenage and late teenage years, we actually require a little bit more sleep again. And then it declines again throughout life until you're getting to your 80s and 90s, and you actually require very little sleep at that point. And so this is a nice graph that kind of shows this. And so you see here, basically right before we're born, we have a significant amount of REM sleep. So, like I mentioned before, you have tons and tons of REM sleep right before you're born, and just a little bit of non-REM. At the time of birth, you're getting about half and half. So you're sleeping most of your day, about 16 out of 24 hours on average. Half of that is REM sleep, and then the other half is non-REM, and it's stage 2 sleep. Because we don't develop slow wave sleep until about 4 to 5 months of age. You'll see that this top line represents the entire amount of sleep. So you can see here that it continues to diminish. This one's a little attenuated, but a lot of the graphs actually show even a slight increase again around the late teenage years that I was talking about before. This one just shows a steady decline, but there definitely is increased sleep requirements as we get to our teenage years. And then it continues to decline throughout life. So now to get to some of the little more nitty-gritty stuff, we'll talk a little bit about the anatomy of sleep. again, just to remind you guys, there are three basic states, and we're talking about anatomy and sleep stages. And so the first picture here we see is what the brain is doing from a neurochemical perspective during wakefulness. And I don't want you guys to remember all the names of the different nuclei and all the names of the substances. That's not the important thing with these pictures. What I want you to do is just get a sense of what's in general going on in the brain, because the details are a little bit less important. So the thing I want you to note from this is during wakefulness, everything appears to be activated. You've got a lot of excitatory signals coming from your brainstem, going up throughout the cortex, and everything is awake and activated and really working. So that's the big take-home message from this slide. Then when we get to non-REM sleep, so this is kind of the stage 1 through 3 sleep, let's call it now. As you can imagine, everything gets shut down. So everything is being inhibited. So those exact same neurons, exact same nuclei that were causing all of that activation throughout the cortex are now being inhibited by GABAergic signals from the preoptic areas, so the ventrolateral preoptic areas. Again, I don't want you to remember the nuclei, but just to know that there's inhibition on all these same nuclei that were previously activating the cortex during wakefulness. All these nuclei are now being inhibited. Then during REM sleep, we kind of see a mixture of things going on. This is kind of interesting. So we see excitatory signals coming from some of the top parts of the brainstem and actually activating parts of the cortex. And this is why we see such an awake-looking EEG when we do an EEG during REM sleep. While at the same time, and this is the really important one to know, you're actually getting inhibition down from some of the lower, so the medullary centers of the brain. You're getting inhibition down to all of your spinal motor neurons. So this is the way that our brain can look very, very active if we're awake, but we see absolutely no muscle activity because there's all that inhibition going on onto your spinal motor neurons. And so that's how we get that combination of things that we see during REM sleep. Hypocretin, you remember I talked a little bit about when we were talking about the history of sleep. This is a substance that was kind of very recently discovered in the late 90s, sorry. It's produced by cells in the hypothalamus. And interestingly, and this was quite a breakthrough, it's found to be decreased in the brains in CSF patients with narcolepsy. There's also been narcoleptic animals that have been, engineered, and there's also abnormalities found in hypocretin in narcoleptic animals. And interestingly, hypocretin, and this is a very recent finding, has been found to actually change in levels throughout our life. So we see increases in the level of hypocretin found in the CSF right before birth, during the third trimester. And interestingly, it peaks at 4 months of age. And you'll remember, that's about the time when slow wave sleep starts to come in. So it makes you wonder if hypocretin is somehow involved in this change or development of sleep throughout our age. And this is yet just kind of hypothesized because these are very recent findings, but it really makes you wonder how hypocretin is involved in the development of sleep. And then throughout our life, hypocretin levels slowly drop, just like our sleep requirements do. And you'll see here what hypocretin does. Basically, it activates all of those nuclei that we know are important in the generation of sleep and wakefulness and these cycles. And so it obviously helps not only in the development of sleep, but in maintaining kind of the activity of these nuclei that are so important in the sleep generation. And so hypocretin has been determined to have probably 4 functions, and this is, again, expanding with every year. We know that hypocretin promotes wakefulness, so it helps you stay awake when you want to be awake. That it helps maintain sleep-wake cycles, so it helps you stay in the same cycle. So if you're awake, it makes sure that you stay awake and that you're not getting kind of changes or activity that are normally seen during sleep intruding on your wakefulness. It also helps maintain our skeletal tone during sleep. inhibition, like I showed you, of your spinal motor neurons while you're awake, because you want to be able to move around. And it's one of the substances that's important in stopping that from happening and keeping our skeletal tone normal during wakefulness. And then more recently, like I talked about, it potentially has a role in the process of sleep and wakefulness consolidation that occurs while we're growing up during early infancy. Now, adenosine is another substance that mediates sleepiness after prolonged wakefulness. And so basically, if you were to sleep deprive yourself, we see that adenosine levels increase in our CSF the more and more we become sleep deprived. And the more and more we become sleep deprived, the more that we will transition very quickly and for prolonged periods into slow wave sleep when we do finally fall asleep. And so it's thought to promote this transition to slow wave sleep. It does this by inhibiting basal forebrain neurons, which are important in the maintenance of wakefulness. So the more adenosine we have around, the more sleepy we feel because it's inhibiting these basal forebrain neurons, which normally keep us awake. Caffeine and theophylline, which we take basically to keep ourselves awake, are adenosine receptor antagonists, and so potentially this is one of the ways that they help us stay awake. And so the basal forebrain neurons are these ones here. I just wanted to show you. And so these are the ones that adenosine is basically inhibiting. More and more adenosine around, obviously you get more and more inhibition and more sleepiness. And finally, melatonin is another substance that's important in kind of sleep and sleep-wake cycles. It's released from the pineal gland during times of darkness, and therefore it increases your likelihood to sleep during these periods of time. And in so doing helps us maintain our circadian rhythm. And so we see here how melatonin is controlled by the brain. Basically, as light comes in through the eye, this causes excitation of neurons in the suprachiasmatic nucleus. And the neurons in the suprachiasmatic nucleus have projections down and then up again, which actually inhibit the release of melatonin from the pineal gland. So as soon as you're in the dark, this inhibition is released, and melatonin is allowed to be emitted from the pineal gland. And this is how melatonin release is controlled in the brain. So now we move to the more kind of clinically oriented stuff. I'll talk a little bit about the symptoms of abnormal sleep and some sleep disorders. So some of the most important symptoms that we try to elicit during the history of a patient that we're seeing that might have a sleep disorder are listed here. Probably the most important is excessive daytime sleepiness. This can come and tell me about problems that they're having during sleep, but really this doesn't become clinically or functionally important unless that problem that they're having during sleep affects their ability to stay awake. And so we very carefully try to quantify how sleepy they are by using different scales where we ask patients about whether or not they fall asleep during different scenarios. So for example, someone who just falls asleep, for example, if they're in a dark room watching a movie, might not necessarily have as much sleepiness as somebody who says they fall asleep behind the wheel when driving home from work, or even in a meeting around a table with a bunch of people in the room. Obviously that person suffers from a significantly more disturbing daytime sleepiness. So we quantify the degree of sleepiness based on scales, asking these sorts of questions. Other symptoms that people can describe that have sleep disorders is that they have insomnia, and so that they're unable to fall asleep. That they or their bed partner describe abnormal movements during their sleep. That they have awakening, so they may be able to fall asleep, but they finally awaken multiple times throughout the night. That they have abnormal breathing during sleep, and that's generally something you also have to get from a bed partner, That they have something called sleep paralysis. And this is a symptom where a person describes that either as they're transitioning into sleep or as they're first waking up, that they'll notice that they're awake, they can look around, they have awareness of their environment, but they're not able to move anything. And so they've kind of got some of the remnants around of that muscle inhibition that we get during REM sleep, And so they're not able to move anything, they're able to breathe, but they're awake. And so obviously this is very scary. And this is something that people present with rather early because they're worried about it. Truth is, sleep paralysis can actually occur to anybody. So if I deprive anybody of sleep, or even normal people not necessarily super deprived, they can describe sleep paralysis. So it doesn't necessarily mean you have sleep disorder. It's the frequency with which it occurs that's most important. And then finally, hallucinations. Two types. The hypnagogic, so these are hallucinations that you're having just as you're falling asleep. Or hypnopompic, these are hallucinations that you're having as you're waking up. And again, this is a matter of degree, because everybody can get these. And I'm sure actually most of you have had hypnagogic hallucinations. And this is like when you're falling asleep, and you suddenly startle yourself awake because you think you hear a door slam, or you think you hear a voice. And then you wake up and you realize that there was no door slam, or there was no voice. And so you probably hallucinated that, but it's a normal function of sleep, and it's something that can occur in everybody. Again, a matter of degree. So if somebody has this, every time they fall asleep, that might be more abnormal than someone who gets it just every so often or when they're sleeping. So when I'm taking a sleep history from a patient, I ask about any of these symptoms of sleep disorder. It's really important to talk to their bed partner because once they fall asleep, they're not able to tell you what they're doing. So you can ask their bed partner about abnormal movements, about talking during your sleep, about abnormal breathing during your sleep. You ask about medications and habits because almost all medications affect sleep, and a lot of the habits that we have affect our sleep. So habits that are important are when you exercise, how often do you exercise, what time of day do you exercise at, if they smoke, if they drink, if they do other sorts of illicit substances that might affect their sleep. And all of these things are really important because they significantly affect your sleep. Other medical illnesses, and that's because there's certain illnesses, for example, neurological illnesses that affect your ability to sleep. Or alternatively, your sleep can actually worsen or affect illnesses. So, for example, people with congestive heart failure can have a worsening of their congestive heart failure with poor sleep. So you both want to ask about things that can affect their sleep or things that their sleep might be affecting. And then finally, a family history, because a lot of the, for example, abnormal movements during sleep, sleep terrors, sleepwalking, these sorts of things, really run in families. So it's very important to find out what other family members are doing. So now we'll talk a little bit more about some sleep disorders. So health is the most boring, but honestly, this by far and away the most common cause of sleepiness is just plain old insufficient sleep syndrome. And this is just people who are doing too much and not allowing enough time for themselves to sleep at night. Daily sleep requirements range from person to person, and like I showed you before, they range over a lifetime. So a lot of people are getting insufficient sleep when they don't even realize it. A lot of people think, how much sleep do I need during the night? And most people will say, probably about 7, 8 hours maybe if I'm having, a period of time in my life where I can't sleep more. Truth is, though, this can range. And if you're the type of person that needs 10 hours of sleep a night, by limiting yourself to 8 hours a night, you can become sleep deprived. And so it's not like there's a magic number that every person has to get. It ranges from person to person, and it's something that you have to figure out for yourself. And this is so common that a huge number of people have it. So this recent study from 2012 actually used telephone interviews. This was done in the States, and they interviewed close to 8,000 or 9,000 people. And they asked questions based on the sleepiness scales that we use in the clinic to figure out how sleepy people are. And this study found that nearly 20% of the people that they interviewed over the phone had symptoms that were consistent with moderate excessive sleepiness. Moderate excessive sleepiness is functionally disabling. It affects your life. So this is significant. And then 11%, which is a really high number, like 1 in 10 people, reported severe excessive sleepiness. And this is the type of sleepiness that significantly affects your life. These people are falling asleep behind the wheels of their cars, they're falling asleep in important meetings, these sorts of things. So that's a significant number of people that are describing this. And the vast majority of these people, it was associated with this insufficient sleep. So no fancy sleep disorder, just plain old not sleeping enough at night. There's a lot of effects of insufficient sleep. So we know that chronic sleep deprivation, so it doesn't have to be much, 1 or 2 hours a night for a period of time, can lead to weight gain, to increases in their blood pressure, and to diabetes. It's actually been shown that 1 night of sleep deprivation impairs hippocampal function, and the hippocampus is the part of the brain that's important in creating memories and remembering things. And this can result in actual deficiencies that you can find on neuropsychological testing in a patient's ability to commit new experiences to memory. And this is really important to remember when you're trying to get into the period of time when you're studying for your exams. Because a lot of us, let sleep go in favor of potentially getting a couple hours more of studying in. And you have to ask yourself basically what the cutoff is and when it becomes to the point that you're actually impairing your ability to learn these things that you need to learn. Sure, if you're doing it for 1 night, just to cram for the exam the next night or the next day, but it becomes different if you're doing this for a week at a time, because obviously as you get through the week, your ability to remember things is becoming less and less and less. So at that point, potentially a couple hours more of sleep will do you a lot more good than a couple hours more of reading. And just to highlight this, there's been some really interesting studies done recently, and these were all 2010 to 2011, in kids who are sleep deprived. And so this first study, this study at all, they sleep deprived actually grade 4 and grade 6 kids. And they didn't sleep deprive them by much, because you can't really actively do that to kids. They sleep deprived them by about 30 to 60 minutes per night. So all they did was they just woke them up half an hour before their normal bedtime. And they did this only for a few days. And they found that just after 3 days of this relatively small amount of sleep deprivation, that there were significant differences in the performance of these kids. So the grade 6 kids, after 3 days of mild sleep deprivation, actually performed closer to the grade 4 kids than they did prior to that. So obviously that's a pretty big difference. In this other study, this is more of a kind of epidemiologic study, this Waldstrom et al. Group actually looked at the amount of sleep that was reported by kids who obtained different grades in school. And so they looked at high school students, and they found that kids that got A's had on average 15 minutes greater sleep than those who got B's. And those who got B's had on average 15 minutes greater sleep than those who got C's. So it's hard to say, it's kind of chicken and egg, what's the association here? But it's just interesting that in these large studies, that even very small amounts of sleep deprivation seem to result in very different abilities. And this final study I thought was interesting because it's a little bit pertinent to you guys at your stage tonight. In this study, they actually studied college kids and university kids who would drink on weekends and tended to drink a little bit more and were kind of binge style than some of their older counterparts. And what they did is they took kids, and these were both students they were all students who drank a lot on a weekend. And they asked them questions about how drinking affected their life. So whether or not they ever missed a class because they drank too much, whether or not they missed out on studying for exam, whether or not they performed more poorly on an exam. And they found that in groups of students who actually drank the same amount of alcohol, that those who had lesser sleep quality and lesser sleep actually had more negative consequences from their drinking than those who drank the same amount but slept more. So again, just highlighting the importance of sleep and how it affects your functioning in life. Now we'll talk a little bit about narcolepsy, and it's a very kind of interesting sleep disorder. We know a lot more about it since we discovered hypocretin or orexin, depending on if you're North American or European. So there's 4 classic symptoms of narcolepsy that we talk about. The first piece, the most important, the one I talked about to you guys about as the most important kind of symptom of any sleep disorder, is excessive daytime sleepiness. And these people would have the severe type where they're falling asleep basically at very inappropriate times. So inappropriate that they talk about actually sleep attacks in these people, where they'll be in the middle of doing something, for example, in class reading, speaking, and and then suddenly fall asleep. Cataplexy is another symptom that these patients get. And this is basically an intrusion of that loss of muscle tone that you get with REM sleep while you're awake. So they'll suddenly lose all the tone of their muscles, so they'll fall to the floor, they'll be unable to move, but they'll still be awake, so they'll still be aware of their surroundings. So these people also get lots of sleep paralysis, which is kind of the same thing. That's the thing I talked about that anybody can get, but happens significantly more in these patients where they wake up, they're completely awake, but they're unable to move. And finally, they also get the hypnagogic and hypnopompic hallucinations that I talked to you about, but again, with significantly more frequency than a normal person would get. So here I have a short video. This is actually really old, but it's a CNN clip on a kid who had narcolepsy. I think I'd like to show it. It's really interesting because it talks about the symptoms. I think it's a nice way of remembering everything that happens in these patients. So just last 15 minutes, so you guys, let me know if you need to turn things off. Here we go.
Welcome back. We are bringing you some of the most compelling mysteries of the mind tonight, and this one strikes during adolescence and makes otherwise normal teenagers collapse. Not just into a deep sleep, but into a mysterious netherworld, a world filled with hallucinations, paralysis, and strange sensations that strike without warning, linger without a cure, and can last a lifetime. An insatiable need for sleep. Sudden episodes of paralysis. Vivid hallucinations. This is the life of a narcoleptic.
I don't really even remember a whole lot of my sophomore year just because I slept so much through my classes.
Anthony Raymond, a normal high school kid, loved acting and the theater. Then his life mysteriously started to change.
I just started feeling sleepy throughout the day. I didn't think much of it. I just thought it was some weird puberty thing.
Occasional daily naps turned into a constant need for sleep that he could never satisfy.
I was sleeping every chance I could get. In addition, I started experiencing all these other weird symptoms like sleep paralysis at night.
And what is it exactly?
I'll be laying down. All of a sudden, I can't move any part of my body. And usually, what will accompany this are these hallucinations, which not only do I see things and hear things, but I also feel things. I can remember one time being completely paralyzed and feeling a fox kind of crawl under my back.
Can you scream when you're paralyzed like that? So you can't move your body at all?
Scream. But eventually I break out of it and I will scream or something.
And then there's the most difficult and potentially dangerous symptom of narcolepsy, cataplexy. At any given moment, Anthony would collapse. He would be paralyzed for minutes at a time.
Probably the scariest thing is falling to the ground and not being totally sure that you're going to fall in a position where you can breathe. I could fall in a space where my face might be smothered by, a cushion or something.
In extreme cases, like this Scottish girl, it can happen more than 45 times a day, usually brought on by emotional excitement like laughing, anger, or surprise. Experts estimate that at least half of narcoleptics have cataplexy. For Anthony, these sometimes daily episodes make driving, working, and dating nearly impossible.
It starts in the neck, the tongue, unable to move those parts, and then it goes to the legs, and eventually you can't move anything.
And there's nothing you can do to pull yourself out of it?
Nothing I can do except wait. I can try really hard to move, and every now and then I'll gain just enough strength that I might be able to jerk my arm up or something. But
And are you consciously thinking, I've got to ride this out for another minute?
yeah, it's just kind of like that bad dream where you can't move and you can't scream.
Anthony's was really a classical case when he came to me. This is a perfect slide.
Dr. Manuel Mignot is Anthony's doctor and the director of the Center for Narcolepsy at Stanford University. He says that despite all the sleep Anthony gets, he's never well rested.
They're exhausted all the time, they take a little nap, they feel better, but then after 1 hour, 2 hours, it just starts again. And at night, it's the same thing. It's just exhausted, and they arrive in their bed, boom, they sleep, and then after 2 hours, they wake up and able to fall asleep. Basically, the cause of narcolepsy is very simple.
Narcoleptics can produce a brain chemical called hypocretin. Normally, it helps you stay awake. Without it, narcoleptics constantly fall into REM, or dream sleep. But they do not fall into the deep restorative stages of sleep, so they wake up too soon and wake up tired. The mystery: what causes the death of these precious brain cells, and why does it often happen during adolescence? The other mystery: how to restore or replace those cells and cure narcolepsy. Fortunately, doctors have developed drugs to treat the symptoms.
It's kind of gross, but it does the trick.
Every day and every night, Anthony takes a carefully prescribed mix of drugs.
Yeah, I got about 20 minutes and I will be asleep.
One drug gets Anthony's brain and body into a deep restorative sleep, so he's well rested. It also helps reduce cataplexy, but it doesn't work for long. Anthony needs a second dose in the middle of the night.
It is 2:11 a.m. and I am awake again.
Anthony also needs a stimulant during the day and antidepressants to ease his constant sleepiness and cataplexy.
Okay, it's now 7:30 in the morning and
But even with all those drugs, Anthony can only stay awake for about 6 hours at a time during the day, so he must follow a strict daily nap schedule. The first is in mid-morning, usually in his first or second class. Anthony closes his eyes for 15 to 20 minutes.
If he's sleeping, he's going to the sun. But I think he more than compensates for that.
He also has to take a nap the minute he gets home from school.
if I postpone a nap long enough, I just can't really function.
But no matter what medication he takes or how many naps he has, Anthony still has occasional bouts of cataplexy. See his bobbing head here? This one happened while he was watching a comet. But despite all these challenges, Anthony still has big plans for the future. He starts college in September and hopes to become a teacher. With no cure on the horizon, Anthony is ready for a life he knows will be a non-stop, 24-hour game of the clock.
I can live the rest of my life with this. Narcolepsy is a problem, but it's not the worst thing in the world for me. It could happen, and I'm still living.
And you know you can handle it.
Yeah.
And Anthony is doing a whole lot more than just handling it. He has to be thriving. He is far from alone, though, when it comes to struggling.
So I kind of like that concept just because by seeing a person with it, you really can kind of picture the symptoms and remember it. And I just want to highlight a few things that he kind of mentioned and talk a little bit about how they happen. So we talked about how when sometimes you have cataplexy, he was afraid that he could stop breathing. Now, I told you how all of your muscles basically lose complete tone. But as you can imagine, during REM sleep, because this is really just an intrusion of REM sleep into wakefulness, you obviously still have the muscle tone to breathe. And that's because the muscles that are involved in breathing are not inhibited. So when he talks about being able to breathe during these attacks, he's really talking about, like kind of like he highlighted, the position he's in. Because your breathing muscles are still working, it's just that if he falls asleep, for example, goes into a cataplectic attack when he's curled up and unable to actually open his airway from a physical point of view, that's what causes him to be unable to breathe. His breathing muscles still work, it's just whether or not he's able to, from a functional perspective, if he's, his face is twitched or his actual airway is twitched. And then the other thing I wanted to highlight is how he mentioned that cataplexy tends to happen during emotion. And it's interesting because this is very much the case. And if you talk to cataplexics, they mention very specific types of emotion. For example, I've had a patient tell me that their cataplexy would not happen if someone else were to tell them a joke. So if they're watching television, they heard a joke on television, and they were to laugh because of it, but they wouldn't necessarily get cataplexy. But if they themselves attempted to ever tell a joke, so you know that mirth that you feel right before you're going to say something really funny and you're kind of proud of yourself? That mirth for that patient was what would cause cataplexy. So if they attempted to ever kind of tell a joke that they would thought was really, really funny, it's that mirth that would cause a cataplexy, not necessarily hearing somebody else's joke. So it can be very specific emotions that cause the cataplexy. Again, very interesting. And like that video highlighted, it's a deficiency in hypocretin you see in patients with narcolepsy. As I mentioned before, hypocretin is produced by cells in the hypothalamus, and it's found to be decreased both in animal models and in patients, in the CSF patients with narcolepsy. And for most patients, narcolepsy is a clinical diagnosis, so we just diagnose it based on the symptoms that they tell us about. But you actually can use hypocretin levels in the CSF to make the diagnosis as well. And just a reminder, where hypocretin activates all the neurons that are generally involved in promoting wakefulness and promoting transitions between your sleep cycles.
Maybe we'll do that with the serum ones, or would they actually do the lumbar puncture?
You have to do a lumbar puncture, yeah. Because these are all CSF levels, because hypocretin isn't actually found in your skin. It's a neurochemical, so it's not something skin. So any other questions about narcolepsy or any of that stuff right now? So obstructive sleep apnea, I also wanted to mention, again, a little bit less interesting, kind of like the insufficient sleep, but something worth mentioning because it actually is the second most common cause of sleepiness after insufficient sleep. And this is where patients generally have a temporary pause in their breathing while sleeping. And this is occurring because you're actually obstructing your airways and your ability to breathe. And so as we fall into deeper and deeper sleep, and this is not even during REM sleep, this is just in plain old sleep, you still have muscle tone, but your actual muscle tone diminishes. You get more relaxed. And so because of the diminishing in your muscle tone, your airway muscles relax. And in people who are generally overweight or who have very thick necks, you can imagine all that extra tissue can squish their airways. And so as you fall into a deeper and deeper sleep, your airways can collapse, causing you to be unable to breathe. And after a period of time of being unable to breathe, your body just basically wakes yourself up in an effort to increase that muscle tone and to get some breaths in. And so because of that, people with sleep apnea actually have up to hundreds of awakenings every hour, because every time they try to fall back into a deeper sleep, they wake themselves up again because they're unable to breathe. Because of that, they're obviously not getting a good restorative sleep throughout the night because they're never getting back down into slow wave sleep because they keep waking themselves up again before they do. Generally associated with obesity, as you can imagine, because people with a lot more tissue have a lot more pressure on their airways. And it's also associated with snoring. The snoring actually occurs as our airways become squished and there's only a very small amount of space for the air to go through, causing that sound. And so this is a picture of basically all of the tissues, and as they relax, you can imagine that they basically block the air. The treatment for sleep apnea is actually not a drug, but the best treatment is actually a CPAP machine. And basically what this machine does is pushes air into your airways, and therefore opens up the airways and pushes aside those tissues that are squishing the airways shut. And the reason it's really important to treat people is not only are they excessively sleepy, but also obstructive sleep apnea is associated with increased risk of heart attack and stroke. And so as a prevention measure, it's important to treat these people. Now finally we'll talk about some sleep disorders that are associated with abnormal movements during sleep. And again, as restless leg syndrome, which actually occurs before you fall asleep. And then there's two types of parasomnias that I'll highlight. Sleep terrors, which come out of slow wave sleep, and REM sleep behavior disorder, which comes out of REM sleep. And so restless leg syndrome is actually something that originates in wakefulness. And this is an uncomfortable sensation that people get in their legs. And because of this uncomfortable kind of creepy crawly sensation, they have an urge to move their legs to get rid of that sensation. That movement actually does alleviate the sensation for a very short period of time until they relax again and they start to get the creepy crawly sensation again. It tends to be worse in the evening and worse when people are resting, obviously, because they're still. So if they're kind of up watching television before they go to bed, that's when people describe the symptoms are at their worst. In the vast majority of patients, there's a family history of this. And if a patient presents with these symptoms, there's a few tests that you can do because there are treatable causes of this. For example, iron deficiency anemia can cause this, and so if you draw hemoglobin and iron levels, you can potentially treat these symptoms just by iron tracing somebody. This is also significantly more common in pregnancy. People with restless leg syndrome, interestingly, when they fall asleep, continue to have periodic leg movements. And so these leg movements that they were doing while awake to try to alleviate these symptoms tend to continue during sleep and actually awaken the person. And so this is what causes the sleep disorder because they're being awakened by these periodic leg movements. This is an absolutely treatable disease. We use dopamine agonists to treat it, but we only really initiate treatment depending on the severity of the symptoms. People who have this, maybe once or twice a week, doesn't really bother them, they're not excessively sleepy, we won't necessarily initiate treatment because it's not necessarily something that needs to be treated because it's not affecting your functioning. But people who get this on a daily basis, who have extreme sleepiness associated with leg movements, we will treat them with dopamine agonists. Parasomnia is an abnormal movement that occurs during actual sleep. So similar to the periodic leg movements, these are abnormal movements that actually happen while you're sleeping. And again, they're further subdivided into the stages of sleep that are occurring now. And so REM sleep, the one I'm going to talk about, is REM sleep behavior disorder. And in slow wave sleep, I'll talk about sleep terrors. But the other types of parasomnias that you can get during slow wave sleep are sleepwalking and confusional arousal. And so again, this is just to highlight one of the take-home messages from this lecture, that when we talk to clinic patients about when these abnormal movements are happening, we really want to talk about the time of the night they're happening in. Because if they happen during the first third of the night, that's when we really think of the stuff that happens during slow wave sleep. And when we talk about the last third of the night, that's when we talk about things coming out of REM sleep. And this is really important because, for all intents and purposes, a REM sleep behavior disorder or confusion arousal can look the same to anybody, to a bed part of anybody, because it looks like the person just gets up, is confused, and is doing crazy things in their sleep. And so, without knowing what stage of sleep is coming out of, we won't know how to treat it because it's very different. So REM sleep behavior disorder is basically the loss of that muscle of atonia that you're supposed to get during REM sleep. So normally we have a nice awake working brain. Those lower medullary centers are inhibiting our spinal motor neurons and stopping us from moving. In various disorders, often associated with Parkinson's disease and certain types of dementia, we see actually the pathology starts lower in the brainstem and then works its way up as the disease progresses. So early on in the disease, when we start to get pathology in the medulla, we can actually get those nuclei that are supposed to inhibit our motor neurons being affected. And so because of that, we're not inhibiting them anymore, and we're starting to act out all of that activity that's going on in our cortex. And so because of that, we actually act out those dreams that we're currently thinking of in our cortex. And so the bed partners of these patients describe that they'll be sleeping, and all of a sudden they'll start to kick and punch and yell out, and it's because they're acting out those vivid dreams that they're having. Significantly more common in the elderly, probably as we're seeing kind of early pathological changes very much associated with Parkinson's disease and other types of dementia that are associated with Parkinsonism. And so you can see it's basically these nuclei that are affected first as the pathological changes that we see with Parkinsonism and things work their way up the brainstem. Now, sleep terrors are a parasomnia that come out of slow wave sleep. These are more common in kids, and actually in kids, sleep terrors, confusional arousals, and sleepwalking can be a normal part of the development. So we don't consider them abnormal or a disease state in kids. What we consider it to be abnormal is if these things continue throughout adulthood. Some people may have them in adulthood, but only kind of provoked by certain things. So if they're going through a period of stress, if they're very sleep deprived, or even if they drink the night before, these are the sorts of things that can make these sleep terrors, sleepwalking, and confusional arousals more likely to happen. And so the best example I can think of this is, somebody again in university who lives in a college dorm, who, the nights after they've gone out with their friends and had some drinks, are a little bit sleep deprived, will get up during the middle of the night and go looking for the bathroom and end up in their friend's room and these sorts of things. And that's because they're actually in a confusional arousal, they're still sleeping. And this only happened and was brought out by the stress and the alcohol that they consumed. Sleep terrors, sleepwalking, and confusional arousals all have a very strong family history. So if someone complains of them, it's almost guaranteed someone in the family has them. And just to highlight that sleep terrors are actually very different from nightmares. So nightmares are generally arising out of REM sleep, and that's because the dreams that come out of REM sleep, like I mentioned before, are very vivid and emotional, and so that's generally what a nightmare is. Whereas a sleep terror, if you arouse the patient during it, they're not going to actually remember a story that's associated with their, with what their actions are during their sleep. So if you wake up somebody, they can't remember what they were scared of or what they were screaming about, as opposed to a nightmare where, especially in kids, for example, who get them more frequently, they'll actually be able to describe a story or something that made them scared. And so, an overview of what we talked about today. So still not much is known about the true function of sleep.
Is it bad to wake the child up that's experiencing a sleep terror?
It's not bad, so it's not going to hurt the child. The reason they say not to is that, in a way, there's no point. You're not going to abort the episode. You could potentially hurt yourself because they're kicking and screaming and have no control over it. And so you don't want them to hurt you or themselves because they're kicking and screaming. And they'll be very confused when you wake them up, so you're not going to remember why they're doing it. So the reason that they say not to is because there's kind of no point. The best thing to do is just to make sure they're in a place where they're not going to hurt themselves, they're surrounded by pillows and things, and let them ride it out. Because as soon as it's done, they'll fall right back into slow wave sleep, and it's not like you'll wake them up and scare them that something bad is happening. Any other questions? So, basically an overview. Not much is known currently about why we sleep. There's a bunch of theories, but again, these are all theories based on some of the things that we find during sleep. And still, not much is known about, how we sleep. We know the stages, we know certain nuclei are going on in the brain, but we often don't know what turns on and off these nuclei at different stages of sleep. So there's still a lot of research that needs to be done. Sleep stages help us define normal sleep throughout our lifetime and are used to characterize sleep disorders, but again, are just a way of classifying things. So you have to take it all with a kind of a grain of salt, that it's not necessarily something that defines our sleep, but it's a way that we use to kind of communicate with each other and define sleep disorders. Sleep disorders are extremely common, like I highlighted, and their symptoms can have very significant effects on people's lives, as we saw in the video, and as we can see with people with excessive sleepiness. And so it's very important to ask about the